Good morning. Today we'll be talking about stroke, its prevention and rehabilitation. And with us, we have two very interesting doctors. Thank you, Dr. Odemuyiwa and Dr. Ninalowo, for coming on the program with us. It's a pleasure to have you here today.
Thank you for having us.
So, if I can start off with you, Dr. Odemuyiwa, can you start off by telling us what is a stroke? How does it occur?
Right. Thank you again, Pamela, for having me. A stroke, simply put, is the death of a part of a brain. It is loss of function of a part of the brain. And therefore, the areas that that brain controls, the functions that the brain controls in that particular part of the brain do not exist anymore or are decreased or diminished. And we have a scourge of stroke in Nigeria. I mean, we have an incidence of 1.14 stroke patients per thousand, which is 1,140 patients per million. So in Lagos, for instance, where you have about 20 million people, you have over 20,000 strokes a year. So you can see that it's quite an epidemic. And that's a lot of people. 10% of these people die within 24 hours. Another 30% die in a week, and 40% are lost in a month, mostly because of the management, post-stroke management. Some people have it in the rural areas. And the other question you asked were the causes of stroke. We can divide the causes of stroke into two main groups. We can call them modifiable risk factors and non-modifiable risk factors. Modifiable risk factors, the top of which will be high blood pressure, hypertension. People who have uncontrolled high blood pressure can develop strokes. And my recommendation is for people to have a blood pressure monitor. In my opinion, every household in Nigeria should have a blood pressure monitor. So people can keep a check on their blood pressure. And then when it gets above 130/80, creeping toward 140/90, you want to see your physician and have something done about it. The next thing is high cholesterol. High cholesterol, people get confused about cholesterol. We have the total cholesterol, and then we have the low density lipoprotein, LDL. The way to remember it is that L stands for lower. The lower the LDL, the better. And then HDL is the good cholesterol, and the higher that is, the better. It is much more complicated than this. You can go into subsets, apoproteins, and stuff like that. But for the simplicity of this talk, just remember that the lower your LDL, the better. The higher your HDL, the better for you. The other thing that causes a stroke is smoking. Smoking is a big risk factor for having a stroke. People who smoke double their risk of having a stroke. Okay, they double their risk of having a stroke. The next one is substance abuse. Cocaine and things like that can cause a stroke. It causes vasoconstriction, the arteries narrow, and therefore compromised blood supply distant to that organ. And of course, we talk about obesity. People who are obese can develop a stroke. And we also talk about sedentary lifestyle. All right, people who are sedentary, who don't exercise much, can develop a stroke. There are many things to do. There are many aspects of that. When people are sedentary, they can increase their risk of stroke. And then when they get a stroke, it is worse than other people, and then their recovery is slower. And then the big elephant in the room is diabetes. Diabetes can cause a stroke because of the microvascular complications of diabetes. All these are modifiable risk factors. I'll run through the non-modifiable ones really quickly. The age, the older you are, the higher the risk of having a stroke. And then the sex. Men have more strokes than women, even though women have it earlier. And then women tend to die from strokes more than men do. Family history of a stroke. When someone's relative has had a stroke, like Carrie Habitat, we cared for a young lady in her 40s who had a father had a stroke, her brother had a stroke, she had a stroke in her 40s. All right. The race and ethnicity, Black people tend to have more strokes than other people. And then if someone has had a prior stroke, it predisposes you to another stroke. All right. You have a higher risk of having a stroke, and therefore you have to have aggressive secondary prevention done by your physician. And then, of course, people who have heart attacks also have strokes because of the way the heart functions. Anytime there's stasis, anytime the blood pools, it can form a clot. And talking about the types of strokes, there are two main types. There's the one that is caused by blood clot. I'm sure Dr. Ninalowo will talk more about that. That is
Definitely.
much more common than the one that is caused by a bleed. Other factors that can cause a stroke is sickle cell disease. A lot of people with sickle cell have a stroke. 24% have developed a stroke at the age of 45. And then we talk about people with atrial fibrillation. Atrial fibrillation is an abnormal heart function. The heart is not beating in synchrony, it's kind of quivering. And when it quivers like that, there's pooling of blood. Anytime that blood pools somewhere, you can develop a clot, and then the clot is propagated. And then there's another one that can be caused with amyloid myelopathy. There's a deposit in the brain. And then a big one that we've been seeing a bit of in Lagos now is an aneurysms. Dr. Ninalowo, I'm sure, will talk about that. And then arteriovenous malformations can also cause a stroke. So these are all the things, most of the things that cause a stroke, modifiable and non-modifiable risk factors. The ones you can do something about and the ones you cannot do anything about. You can't change your age, you can't change your sex, you can't change your ethnicity, but you definitely can control your blood pressure, your smoking. Stopping smoking is a major thing that one can do. So that's what it is in a nutshell, how to prevent what one can do to prevent a stroke, basically, and what a stroke is. And depending on what part of the brain is affected, it could affect your speech, the person's speech. It could affect the eyesight if it affects the occipital lobe. It could affect mobility. Part of the body could be paralyzed. The arm could be paralyzed completely or partially. The legs could be paralyzed. You could have problems with continence, problems with swallowing. Swallowing is a big part of it because that is how a lot of people die from strokes because of aspiration. They're not able to control their airway. As most of us know, there are two pipes at the back of the throat. One is for food, one is for air. The one for food can take air in, the one for air cannot take food in. And therefore, people aspirate and then they have pneumonia, they have recurrent pneumonias and stuff like that. So one of the first things that is done within the 48 hours of having a stroke is to check the swallowing to make sure that the patient can swallow. That is a big part of it. And then one gets a speech therapist involved to try and do some other things regarding the swallow. And sometimes the patient might end up having a feeding tube because they just can't control that airway. So that is those are some of the things that can occur and some of the ways to try and prevent a stroke. Some are not, some of them you can't do anything about, like having an aneurysm. Some are congenital, some are acquired. I think I'm sure Dr. Ninalowo will expand on that, but anything that is less than 3 millimeters or so, not a problem. But when it gets to 7 millimeters, it starts to be an issue. Then there are some interventions. I'm sure Dr. Ninalowo will expand on that.
Telling us more about that. Well,
Yes.
thank you. I think you've really given us a beautiful, very succinct, sort of summary about what a stroke is, what a stroke does, and how people can present. Can I ask you, in the past, we used to have a lot of issues with people saying, oh, no, this is a spiritual attack. Does that still occur? There's been a lot of education now among the populace, but do they still think it's my village people doing me or something? Is that still a reality amongst our people today?
Yes. Our people believe that anything that happens to them suddenly and unexpectedly it must be some ulterior, some external forces. But to be honest, I mean, all they have to do is to look inward. Some people go about with blood pressures as high as 220 over 160, and they don't even know that they have that a level of blood pressure. Many undiagnosed diabetics walking on the street, and then people smoke, and then on top of smoking, some people take illicit drugs, which is just fueling the fire. So thinking that your neighbor has done you harm is not is not what it really is, because people are doing themselves harm by not checking these things. And one should actually have a physical once a year in order to check blood pressure, cholesterol, and all these things to make sure that they're good. I always tell my patients that they need to know their numbers. Know their numbers, know your BMI, know your blood pressure, know your A1C, know your cholesterol level. And for men, they should know things like their PSA and stuff like that. So that's one thing that people need to know. You need to know your numbers. If you can't find out yourself, go to your doctor and ask him about what your numbers are so you can reduce your risk for stroke.
No, I mean, amazingly, that's something that we used to, I mean, for years on this program, Know Your Numbers was a huge thing for us. And right now, there's a huge campaign on by the by the there's a huge campaign on by the the commissioners of health and so on, trying to get people to go out there and check their blood pressures because of how important it is for Black people to have their blood pressures checked. It's such a simple test, and free. You can walk into any pharmacy and actually have your blood pressure checked. And yet most people prefer to know. They believe in the adage, they know what they don't know can't hurt them, but it really can.
Yes, yes. I must commend the state government for this effort. I mean, I had a friend who carried out a pilot program in his own village. He armed Okada drivers with blood pressure machines as well as blood sugar machines, and told them to go out in the community to check blood sugars randomly and blood pressure and report back to him. And he was able to reduce the incidence of stroke marginally, even though marginally. But it was a good pilot study to see what one could do, because just controlling blood pressure and blood sugars alone would help tremendously to reduce this scourge of strokes that we have in the community, at least to reduce our modifiable risk factors. The ones we can't do anything about, we just can't do anything about. So I think it's important for each person to look at what they can do for themselves and their families.
Thank you. Thank you very much. Wow. It's such a pleasure to have you with us once more, Dr. Ninalowo. I think I want to really celebrate your achievement of being, able to, and I want you to share with us exactly how it was done, how you prevented a stroke through your, interventional radiology. It's really exciting that such technology is being used in Nigeria and having such positive results in Nigeria today. I want to say congratulations to you on that. And can you describe exactly what happened, please?
Oh, thank you very much, Dr. Pamela. So stroke intervention is very prolific everywhere else in the Western world because, as you know, stroke can't be prevented. It can be prevented with preventative factors like Dr. Odemuyiwa talked about. But when a stroke does happen, there are certain things you can do basically to stop a patient from getting worse. So one of those treatments is something called mechanical thrombectomy, which is a procedure where you could go into an artery in the wrist or go through an artery in the groin and put a catheter in the vessel in the brain that is blocked and suck out that clot with something called a stent retriever, or just suck out the clot with just suction, right? Mm-hmm. And as I said, this is something that's been available everywhere in the world for a long time, but we've never had it in Nigeria. And we've always had a dream of bringing more and more technology into the space. As you know, in Nigeria, it's very, very difficult to get somebody who is having a symptom of something in an emergent setting and getting them to a hospital to do something very fast. And we just so happened to have this patient who, they were having symptoms of a stroke. And one of the family members called me immediately, and we were able to get them to the hospital within the 6-hour window. And we were able to go into the groin, go into the vessel in the brain that was blocked, and we removed that clot. And interestingly, after that first one, we've done 2 more patients just in the last few weeks with very good results. And Dr. Odemuyiwa knows that they used to send him a lot of patients that have had strokes from the hospital, but 2 of those patients were able to go straight home instead of rehabilitation, which is a big deal, right?
It is a big deal, very, very big deal. And I think that, for me, it's exciting that this technology is here in Nigeria today. It's exciting that you are able to do it. And I would say congratulations, and congratulations to us all for having this ability to do this. It's tremendous, it's phenomenal, and awesome, and I'm really really happy about it. Now, what are the key things though for a person to have this successfully done? You know, I know that, I mean, obviously, a person pitches up 2 days after the stroke, there's nothing you can do for him. So, how do you, you know, for example, I mean, obviously, we don't want to have a stroke at all. But if we're having a stroke and we want to take advantage of this new treatment that's available, how do we do that?
So the biggest thing to remember is that time is brain. Basically, when the vessel in the brain blocks and those brain cells that start to die, the more time you wait, the higher the chances that those brain cells are completely dead and the damage cannot be reversed. In order to be able to do something for a person needs to present to the hospital within a few hours of having a stroke, right? And if we could get into that brain within 6 hours of having the stroke and removing the clot, the chances that the brain will recover is very, very high. In some patients, we could stretch that window up to 24 hours. The good thing now is that we also have technology, basically, it's called CT perfusion. And we could determine by doing this imaging test how much brain cells are completely dead and how much penumbra we have, which means the brain that could still be reperfused and brought back to life, right? So we have all of that technology now. But I think what's most important, I know you've talked about my achievement quite a bit, but what's most important to talk about is that we're still a drop in the bucket in Nigeria, right? If you look at the UK, for example, they have 40 stroke centers that could do this for a population of about 54 million people. We have 250 million people in Nigeria, and we're really celebrating the first mechanical thrombectomy that's been done. We're celebrating 3 now that's been done in the last month. If you look at a country like Kenya, they've set up 2 stroke centers already that have been doing mechanical thrombectomy for a while, right? So we low to medium income countries, we really, really need to step up. And how are we going to step up? Is by training more people to do this. We're already trying to do that to make sure that there are more people available that could offer this service in the country. We want to train the interventional cardiologists also to do this, the neurosurgeons to do this, so that we could offer care to way more patients. But this is going to require a lot of cooperation between private entities, the government, and recognizing that this is an epidemic. I think we understand that stroke care is expensive, right? But what is more expensive is when you have a stroke and you have to deal with the rehabilitation for a very long period of time. You've lost your quality of life, you've lost your ability to earn, right? But if you could provide a treatment that may be somewhat expensive in the start, but could have that person recovered function and go back to living a full life, it is much less expensive. So I think we still have a long way to go. I know we're celebrating this achievement, but it's not even a drop in the bucket.
Wow, and that's actually then brings us back to Dr. Odemuyiwa, because we have so little of this kind of intervention, we need the rehabilitation. So, Dr. Odemuyiwa, can you tell us about rehabilitation and what stroke rehabilitation can do, and when do you advise the people come to you with for that?
Thank you very much for this opportunity again, Pamela. As you know, Caring Habitat is the first purpose-built inpatient rehabilitation center of its magnitude in Lagos. We have 40 beds. And what we do is we have a combination, a multidisciplinary team. And stroke rehabilitation should actually start within 48 hours of having a stroke. It starts with evaluating the patient's swallowing to make sure that the patient can swallow and whether the patient can eat or not. If the patient cannot swallow, then we advise an alternative means of feeding, something like a PEG tube. A nasogastric tube, passing a tube through the nose, is a temporary means of feeding, and it could be risky because it could be dislodged and can cause aspiration. So as soon as we get the patient at our place in Caring Habitat, we assess them. We do a physical assessment, speech assessment, as well as occupational therapy assessment. And we do aggressive rehabilitation of up to 3 hours a day. Dr. Ninalowo can attest to the fact that he hasn't mentioned it, but he had patients with aneurysms as well, which is part of what he does, coiling aneurysms and making sure they don't rebleed and stuff like that. We've taken in some of those patients and we're successfully rehabilitating them, getting them to speak again, getting them to walk again, getting them to be able to carry out what we call their activities of daily living, bathing, grooming, dressing, mobility, transfers, continence, and all that stuff. And in addition to this, we are able to provide assistive devices for patients before they leave. For instance, if they're paralyzed on one side and they can partially move one arm, we can get them a brush to be able to brush their back and bathe themselves. We can teach them how to transfer from the bed to the chair, which is huge. One might think that that is not a problem, but it is huge.
A big one.
It gives them a little bit of independence. We can get them a shower chair. We can get them a walker. We can get them a cane. We can get them a 3-pump cane. We can get them even electric wheelchairs. We have them in stock. We have a huge mobility warehouse at our place. So the first thing we do is to evaluate them, see what they need. Physical therapist sees them, right? Speech therapist sees them to teach them how to talk again. And then the occupational therapist comes in to teach them how to get back to their pre-morbid functional status. For instance, we had a lady who was a secretary. She was an executive secretary. So we had to teach her how to type again. Well, we have people who are not able to talk. We had to teach them how to talk again, starting with A, B, C, D, and all that kind of stuff. And then it's important to be able to get this rehab in within the first 90 days of the stroke. If you wait after 90 days, if you wait and you don't do anything within that window of opportunity, those people might be stuck in that state. And you see people that have had a stroke and they have the contractures, they can't move their arms, they can't move their legs. After the first 90 days, the amount of improvement you can get is only about 10% a year, 5 to 10% a year. So you see people that are stuck and nothing can be done apart from giving them Botox injections or something like that to release the contractures. Some of them are bed bound. And even when they are bed bound, physical therapy helps because it prevents blood clots. It also prevents pressure sores. We have air mattresses are carrying habitat where people use, and it kind of turns the individual or left, right, and center just to prevent them being on one side for a prolonged period of time. So a lot goes into rehabilitating a stroke patient. Like Dr. Ninalowo said, it's quite expensive, and the best way to do it is to prevent the stroke from occurring in the first place. But at Caring Habitat, we provide this multidisciplinary group. We have physicians who are there 24/7 to take care of the blood pressure, to take care of the diabetes, to take care of whatever problems the patient develops. Then we have the therapists, physical, like I said, speech, occupational therapy. And then we have the pharmacists, and then we also collaborate with the neurologist who's in the patient, and Dr. Ninalowo as well, once in a while if he needs to follow up with the patient.
You haven't mentioned the water therapy, which I understand is unique, very unique.
Yes. Oh, yes, we have aqua therapy. We have a huge pool. We have aqua therapy there for people who have sustained falls after a stroke, because once they have fallen, they are fearful of further falls. So this gives them confidence. This gives them confidence to be able to walk. It gives them stable. I mean, you can't fall in water and injure yourself. And we have jets too to give them some resistance training with our aqua therapists. So that is another thing that we provide there. Multidisciplinary approach, assistive devices when they need it. We have all kinds of spoons, curved spoons that you can use to eat, reachers, things that you can use to take something from a table. Our goal is to get people back to an independent living as much as they can, from dependence to independence in the shortest possible period of time. So that's
thank you very much. Now, unfortunately, you can't believe this, but our time is up already.
Wow.
So we'd like to have from you any last words for our listeners, and also for Caring Habitat. How can they reach you? How can they find the Caring Habitat for those who are thinking, I have a relative who's just had a stroke or who is within the 90 days. I want to try and see, how much they can recover. How can they reach you?
Fantastic. You can go online. Contact information is there, caringhabitat.com, www.caringhabitat.com, or you can reach us on 0704 800 0561, 0704 800 0561, or 0201.
No, I think one number, because there's too many numbers. Too much information is too much for us.
Let's do that.
Let's just do that. I'd also like to just ask Dr. Ninalowo, Doctor, what do we need to do? How does a person get access? A person has those symptoms coming on and they need your intervention. How can they reach you? Because this is very important. It's like an emergency.
Absolutely. So I think the best thing is that we've established stroke centers, and the first stroke center that we've established is at the First Cardiology Consultants in Ikoyi, which is 28 Thompson Avenue in Ikoyi. If you or your family member are experiencing the symptoms of a stroke, you should show up to the hospital immediately.
And what are those symptoms? Can you just remind us again as the last words?
Again, facial drooping, the inability to use one arm or your leg, speech difficulties, or falling unconscious, or having a severe headache.
Okay, so I think that's so important for us to know, and we appreciate you both for coming on the program. Thank you very much.
Thank you for watching. Please like, share, and subscribe for new video updates.